very much, Richard. Thank you. Thank you. Thank you for that lovely introduction. And welcome, everybody. It's a pleasure to be here and pleasure to escape winter for 2 months, which I've been very lucky to have done this year. So I thought I'd put the acknowledgements at the front because sometimes they get lost at the end. So I'd really like to thank Dr. Geertje Boschma and the consortium for inviting me for the 2 months. It's been a pleasure, and I've enjoyed the stay very much. The UBC School of Nursing, of course. First Nations University, my home university. I'm located in Saskatoon, but I have been teaching up at the Prince Albert campus, which is about 150 kilometers north of Saskatoon. SSHRC, which funded the original research that this has grown out of, but as we all know, the funding exercise these days can be challenging, so I still like to recognize them for providing that funds at the beginning. Joy Duncan, who is one of the nurses that I spoke with and used her collection. Joy went across Canada in the 1970s with a Canada Council grant and interviewed nurses, and her tapes are all stored in the Glenbow Museum. If anybody ever wants to pick up the gauntlet and run with that, it's a fantastic collection of materials. And she kindly allowed me to use her materials in my dissertation many years ago, but again, I still like to recognize her. And I'd also like to thank the nurses who shared their stories. Some of them don't, most of them don't know they shared their stories because they wrote letters that weren't really meant for interpretation all these years later, but nevertheless, I still like to acknowledge them for their stories. So the area that I understand there may be some people here who are not from Saskatchewan, so I would like to point out. Conveniently, this presentation will focus mostly on northern Saskatchewan. That's because most of my work was there. And northern Saskatchewan encompasses actually more than half the province. It's landlocked province, as you can see there. It encompasses about 250,000 square kilometers, or about half the total mass of the province. And it actually is very different than the image that most people have of Saskatchewan. It does not consist of the wheat fields and the grain elevators that exist in most of our popular imagination, but it's a treed place of the boreal forest, where it consists of lots of rock and water and muskeg. And it's a fantastically stunning part of the country that there's only about 35,000 people, primarily Aboriginal people, living in northern Saskatchewan. But it's a vast part of the province, but it's also a vast part of what Ken Coates, who's a historian, calls the Provincial North. And that's a big band of that subarctic region that runs from northern BC through the Canadian Shield and onto Labrador. So it's a very large area with a very small population. It's been ignored for the most part. It's politically weak. It's economically unstable. And it's home to a substantial Aboriginal population. So it doesn't have the clout that other parts geographically do in Canada. But nevertheless, it's a very special place where I've been very fortunate to have done a lot of research there. I think I have So I'll just move into the general talk, and because there's so many interesting stories, I have written it down, or else I would digress into all the stories. So I'll just move on from here, and then we can have a good discussion afterwards. So nursing has been, as Waldron says, has been the backbone of healthcare provision in the North for decades. I think we all agree with that. The introduction of healthcare services to residents living in northern Saskatchewan actually began following World War II, which coincided with extraction of the natural resources from the region, particularly uranium. Northern Saskatchewan holds about 20% of the world's uranium resources, and which of course began to be mined before the war, but particularly in the early 50s. But when the mines were established and after the Second World War, the economic conditions in the north, and when I say north, I'm meaning northern Saskatchewan, they were abysmal. And government social services were almost non-existent. With election of the Saskatchewan Cooperative Commonwealth Federation, which is the CCF, which is the predecessor of the NDP. With their election in 1944, social regeneration of the North, particularly the integration of the underprivileged into society, was premised on a model in which the exploitation of the natural resources would provide the wealth needed to modernize and provide public services. So as a result, I just wanted to go, these are the places that existed. I've got between 1927 and 1955. So all across, the Greynuns mission had been there since 1860. The Cumberland House had a nursing station there. Cumberland House is right on the Churchill River near Manitoba. They had a nursing station there in 1929 with a nurse that, in fact, it was the nurse that sparked my whole research into this area, which was Avanti Cotter. She nursed there. Eventually, they have provided her with a better nursing station in 1941. Up until that time, she nursed in a log cabin, which was pretty basic. Buffalo Narrows, Sandy Bay, Snake Lake, or Pine House Lake as it's known now, these are the provincial nursing stations. So these were the nursing stations that the provincial government established after the Second World War. They also established one at Stony Rapids. La Loche had a Roman Catholic hospital. The provincial and federal governments shared a facility at Lac La Ronge, not to the nurses' liking, but it was shared, nevertheless. Uranium City, which was a single industry town constructed just for the extraction of uranium, they had a community hospital there, but they also had provincial employed nurses who worked there a little bit in some very basic conditions. And then Pelican Narrows also had a nursing station, but not until 1955. So the promise was of medical care, but it was more difficult in the north. Like when the CCF came in, it was one of their mandates was to provide socialized medical care to everybody in the province, and it laid the foundation for eventually Medicare, which began in Saskatchewan. But at the time, they realized that they could not provide this service to this small dispersed population in northern Saskatchewan. So what they did, the province said, we'll establish these nursing posts, outposts, and for people that are in need of greater care, we will fly them to larger centers. As a result, the province established the first air ambulance system in North America. And here we have one of the nurses standing out front of the plane, and these, it's on a nice day because flying around the north, having done it myself, can often be very challenging, even in contemporary times, never mind in days gone by. But that was the start of the medical system, or the air ambulance system in North America. So the provincial outpost system served as an appropriate mechanism to achieve change, not only because the nurses delivered medical care, but they also assisted in the process of social reform through educational programs and by way of their daily lifestyles. However, northern Saskatchewan wasn't a blank slate on which government, nursing, etc. could inscribe this new order. Because for generations, the Cree and the Dene and the Métis people had shaped the region. They had established boundaries associated with their occupancy and traditional ways of life. Policies of the British and subsequently the Canadian government towards Aboriginal people and their lands also changed the political and social landscape of northern Saskatchewan. For example, treaty making, of which Saskatchewan is all treaty. In fact, that's one of the mantras in Saskatchewan is we are all treaty people, because the entire province was settled by treaty with some changes because some of the terms of the treaties weren't fulfilled, so we're still working through that process. But the treaty-making process between the federal government and Indian people created boundaries that delineated reserve land, which is federal jurisdiction, from non-reserve provincial spaces. So you have islands of reserve land in the provincial picture here. And when the Canadian government assumed responsibility for the Indians, the Indian Act was established to differentiate status Indians from the general population. The provincial nurses, of which were employed at those nurses' stations I pointed out there, were responsible for the non-status, the Métis, and the non-Aboriginal population, while federal Indian Health Service nurses attended to the status Indian population. And I'll just point out here, there were not that many nurses employed by the federal government that were employed at various nurses' stations. Often it was the case of the nurses attending when the treaty parties came through once a year to pay out their annuities. But the boundaries established distinct spheres of responsibility, and that became a tug-of-war for the nurses. This tug-of-war between the two levels of government as each sought to minimize their obligation to providing health care. And often caught in the middle, the jurisdictional differences caused the nurses considerable frustration, of which and they still do. I've heard about this, I think we still do, is the jurisdictional issues, even in urban settings, continues to be an enormous issue. I don't know what it'll take to overcome them. I've heard that I would be a rich person if that solution came up. And this theme came through in the nurses' letters that I looked at, and I'll get to that in a minute. And it was the frustration, the repetitiveness of the comments, etc. But what was surprising is their reaction to this, of being reprimanded perhaps for providing care when they shouldn't have. If a population was status Indian and the provincial nurse canoed 60 kilometers to care for a family, would come back and then would be reprimanded for going up and attending to people that were not under her jurisdiction. But the thing that came out of that most was they never denied care. They found ways, like I'm sure we always do when we're told not to do something, to circumvent it and do otherwise. But, you know, comments like, how can we expect things to improve here if we do not provide care to all the population, not just the segments and silos of the population? So, unfortunately, I can't explore all the complex historical relationships that devolved here between the state and the Aboriginal people. I think suffice it to say that nursing practices and jurisdictional divisions contrasted sharply with one another in this northern, particularly in the northern landscape at this time, because nursing was inclusive and jurisdiction was divisive. But the two were intertwined, and they profoundly affected how the nurses carried out their work. And again, sadly, these differences became more entrenched over time and continued to plague delivery of health care, not just in the north. Less so, I would expect, in the far north, because you don't have the provincial jurisdiction, than in the provincial north and the urban areas. So these are just, I just included it here. It's a bit blurry, but those are all the various treaties in Saskatchewan. And these mark the reserves that are in Saskatchewan as well. And just a treaty map of Canada for your own information. Now, I mentioned the collections that I used were Joy Duncan's collection, of which I only tapped a minute amount of information. It's just huge from the Glenbow. But also the letters written between nurses who nursed in northern Saskatchewan, who were employed by the provincial government, their letters that they wrote between themselves and their supervisors in Regina. And their collection is still housed in the provincial archives in Saskatchewan at the U of S. It was great. Sat down one day to read one account of something, and I'm still reading. So, so it's just rich. It's so delightful, and you get carried away in the stories. And I think the fact that they are written at a time when events happened is much more revealing than when you go back and, you know, interview somebody or relate it. But it's quite fantastic. And all their frustrations, all their delights, their delight of the landscape, their attempts to change things that were often beyond their control and whatnot. But I copied 700 letters just to try and get a sense of things. And that, again, was just the tip of the iceberg. So what I found was I had all these wonderful stories, but I needed a framework to put them in, or else, as Laurie and I were talking about earlier, you have these wonderful stories, but you don't know where to go with them. So in my work, being a geographer, one of the things that I looked at, and I will only talk to this briefly, was the work of Anzi Passy, who is a geographer and looks at how regions are formed. And he is saying, you know, we know government sets boundaries and whatnot, but how are they actually formed? There's much more to it than that. And he said, what we need to look at when we're looking at a particular place, region, is the social and the historical events that happen there, because that plays out in itself. So I used his work, and it did help quite a bit. But then I was trying to connect this with the profession of nursing. And I don't know, perhaps people here have heard of Malone's theory of distal nursing. I found her work, I think it's a little bit older now, but I still found she was trying to make a link between geography and nursing, and I found it very interesting. Her model demonstrates how providing care requires nurses to maintain a spatial proximity with their patients. And as such, it includes three nested proximities. There's the physical proximity, which is the degree of closeness at which nurses provide care. There's the narrative proximity, where nurses learn about their patients through the patient's stories. And the moral proximity, the point at which nurses start to act on the nurse's behalf. So what I did, and I found it very useful, was at least this provided me a framework to indicate how some of the challenges that the nurses faced disrupted these proximities. For example, nurses could not stay in the communities for very long. It seemed that the moment they became emotionally invested in a community and advocated on behalf of the residents, they would be moved. Other times they'd be ignored for years and nobody knew they were there. So things like this, I found it a very useful model. And I'll just provide you with one quote of Malone, which perhaps encapsulates her ideas here. She says, all human relations have spatial aspects. This is true not only because we are all material beings with bodies that move and have volume, but because our proximity to or distance from others and from places have meaning for us. Nursing as a human practice also has spatial aspects. Since the relationship with the patient is considered central to nursing practices, nursing depends at least in part upon sustaining some meaningful proximity to the patients. So I found that, again, a very helpful context. And I actually came up with an extra one of that disrupted, in addition to what she was saying here. I also found a proximity. One of the major things that disrupted these proximities was the frustration or the reluctance of nurses having to diagnose what was wrong with patients. Again, that was a continually running theme. The other thing I looked at here was modernization, and we know that much of Canada has been settled through this form. Modernization simply stressed the importance for societies to become more like Western societies, where traditional forms of authority and belief systems were to be replaced with bureaucratic administration. Once less developed traditional societies shed their customs and they modernized to Western standards, then the belief was that their development would be assured. But the model didn't take into account the societies and the structures that were always in place, nor the local histories that had shaped the place where people lived. But it is under this umbrella of modernization that was applied to many communities across northern Canada, and with results, not always the best either. The last one I'll look at, or just mention here, refer to, is internal colonization, which is Morantz's model. And it talks about here, it was how, or the manner in which modernization unfolded that ultimately contributed to northern Saskatchewan's position as being an internal colony of the north. It was not serviced as well. It did not have, as I opened with, the political clout, etc., to assert itself. It did not have control over the revenues that came out of mining and forestry and whatnot to reinvest. All those decisions were made outside of the region. So the North actually became, according to Morantz, and I agree, an internal colony of different layers, Canada and of southern Saskatchewan. So although many of the programs created to address the gap in living standards between the North and South were well-founded, chronic government underfunding, inappropriate programs, and a lack of local participation in decision-making kept the overall level of services well below that of the South. And this is, again, what nurses constantly refer to. Consequently, northern Saskatchewan emerged as a resource-rich colony of the South, a position where it remains today. So the actions of the nurses are not typically associated with colonization. For example, they were purveyors of benevolent, not oppressive structures. But Memi points out colonization takes place on a number of levels with many dimensions of oppression involved in the subjugation of peoples. Nurses represented the values of the state. They were employees of the Provincial Public Health Department, and as such, they had to conform to the rules and the regulations and the disciplines of their supervisors. The practice of nurses altered the way in which people organized the knowledge of the world around them. While subtle, the nurses were part of the colonization apparatus as a collective, but at the individual level, attitudes and approaches varied between nurses. In all likelihood, the government did not view nursing as a means to achieve their agenda of modernization, because I argue if they had, they would have provided much more support rather than the chronically underfunded nursing stations that they had, because they were very basic. It was constantly, constant writings of requests for resources, books, etc. At the same time, as one of the few non-Aboriginal people in the northern communities, nurses did represent authority. Although in local people made their own decision what was good and was not good for them, but it was still the issue around power. One example is when people appeared to comply with the nurses' ways whilst they were an inpatient in hospital. They would go along with the nurses, they would agree, for example, if they delivered their babies there, they would use diapers, they would go to formula, but they would revert back to their own practices when discharged. And we asked them at one point, well, why do you think people did that? And they said it was out of respect. They were in the nurses' realm, and they complied, but once they left there, they did what they felt was best for them. When an unpopular suggestion was made to local women that they should take up needlework while attending a program at the clinic, the women just simply stopped going. They had no intention. They were there for other purposes. They didn't want to do this. So, and this gets lost in, I think the story sometimes is this resistance, this ability to resist. People just didn't let them come in and walk all over them and make decisions. They had ways, just like the nurses had ways, of expressing perhaps their discontent. And often, in some of the cases, the nurses could do nothing. They adjusted their approach. Sometimes they did, sometimes they didn't. They would write to Regina and say, we don't know what to do, we can't get them to comply, and so on. So the goal of the Canadian state during this time was to dismantle and refashion Aboriginal societies with the expectation that they would be assimilated into mainstream society. As such, the nursing stations and nursing practices were ideal points from which to impart new notions of living to the population. In effect, the nurses and nursing practices played an ambiguous role. They cared and they cured, but in an effort to almost completely transform their daily life, their practices also contributed to change, which at times did some more harm than good. I've got some pictures here of the nursing posts that I'll just go through as I'm talking about this. This is at Buffalo Narrows. One of the things, I'm afraid it doesn't come through that clearly, is the emphasis on making the nursing stations their home places, because this is indeed what they were. So there was always flowers being grown, huge gardens, they canned, they put up preserves, enormous amounts of work in addition to their other duties. Queering, who wrote on Northern Saskatchewan a very interesting book. This is a quote from his book. He says, "The outpost hospital nurses performed heroic feats in caring for the large populations that flocked to them for care. In addition to the challenges of providing medical services far beyond those normally required of nurses, these women dealt with ongoing trials, including stoking wood furnaces, and sometimes very reluctant wood furnaces, poor water and sewage systems, and erratic electric supplies. Living conditions in the nursing stations themselves were often less than satisfactory, with some described as deplorable, poorly equipped, and poorly furnished. In fact, the effort put into establishing a home setting is one of the most notable and consistent comments made by the nurses, as I just mentioned. They grew flowers outdoors to brighten up their surroundings for both themselves and their patients. They requested dishes, furniture, paint, curtain materials, and other items to, quote, freshen up the nursing station and enhance their surroundings. They tended to the large gardens, preserved fruits and vegetables, which provided food for the outpost, but it also served as an example for the local population. The nursing stations also served as places for advancing middle-class values. For example, to assist with the transition to living year-round in permanent communities, programs such as homemakers clubs and sewing groups were organized to encourage Indian women to adopt Western ideas of domesticity, with the hopes that these practices would ripple through Aboriginal society. In one instance, after noting that people did not seem interested in her lectures, the nurse encouraged children and mothers to visit her in her home in hopes that they would gain, quote, some knowledge of cleanliness and ways of living properly. And she reported in her letters being very happy with the results because people came, picked up her habits, observed and picked up her habits, and followed them readily. For how long, I don't know, given the situation. And again, this may have been a sign of respect to do what was expected of them in her setting, but once they went back, how realistic, because many of these homes did not have the same amenities that the nursing stations did. But I think that it's important to remember that the evidence shows that people embraced, rejected, adapted as they saw fit, and they often did go back to their own ways or adopted some new ways. It's not black and white. It's not all or one. It's being human and doing what works for you. Promoting Canada's food guide was often obviously considered very impractical and unrealistic given the northern lifestyle, and the nurses protested this in many instances. This was based on personal taste, the lack of financial resources, not to mention the problems associated with gardening in the subarctic. How realistic is that? People hunted, fished, trapped, and preserved food according to their own traditions, and in fact, the nurses often preferred traditional foods over those that were provided to the nursing stations in their annual shipments. Some of the nurses saw the futility of such recommendations and sought to enhance people's diets rather than change it. For example, they would recommend whole wheat flour rather than white flour, things like that. They recognized the value of traditional foods and activities and noted when caribou and fish were plentiful, people were healthy, and when they weren't, their health suffered. So the picture that emerges of northern nursing is sometimes, and maybe a little bit more often than not, messy and ambiguous. We know that the nurses were professional and caring. They went to great lengths to provide care to the northern population, and their actions helped to mitigate what I believe were some of the worst effects of the rapid change that was taking place in the north. Yet at the same time, the nurses and the nursing stations also encouraged some of those changes which may not have been in people's best interests. This is a nurse leaving L'Orange, always decked out formally, regardless of the conditions. And this is Cumberland House. You can tell it was a log house originally with the flowers growing. Always note, I'm afraid it's a blurry pictures. And this is Jean Cuthand Goodwill. And Jean was the first RN. I can see head nodding, so people must know her, which is nice. She was the first Indian or First Nations woman trained in Saskatchewan as an RN. And Jean said she was amazed. I've paraphrased it a bit, most of all it's a quote from her. She was amazed at how well the non-native nurses, with their high ideals, their curiosity, determination, and strong sense of responsibility, managed to cope with the adversity encountered in the northern setting. She felt the setting offered comfort to the nurses as they tried to deal with the human devastation resulting from the imposition of another way of life on Canada's Aboriginal people. So just to conclude here, nurses lived and worked amongst their patients in small, remote communities, which made them effective vehicles for promoting certain principles through preventative and educational programs. This situation left nurses in a confusing and often difficult position because the institutions behind the initiatives to modernize the region were the same institutions that employed them, so they had certain obligations. Furthermore, the paternalistic or the colonial attitude actually extended to the region, northern Saskatchewan, also extended to the nursing stations and the nurses themselves. Often their requests for a jeep in one instance, instead of having to walk extraordinary amounts of distance, were denied because they thought that would be utterly ridiculous to see a nurse in a jeep. And it was just, they were dismissive quite often. The introduction of nursing posts illustrates how a complex mix of changing conditions and human actions alter a landscape, both physically and socially. The small cadre of nurses played an ambiguous role both as agents of modernization, but also as opponents of its most egregious effects. Unfortunately, because of events that they were ill prepared to handle, the situation for the predominantly Aboriginal population living in northern Saskatchewan grew increasingly stressful and difficult. Many northerners, as well as the nurses, armed with the best of intentions, could not contend with the incoming economic, social stratification and political structures that subsequently inscribed the physical and cultural landscape of the region with their own imprint. And that concludes my presentation. Thank you so much, and I really look forward to some thoughts you may have.
Thank you so much, Lesley. There's lots of food for thought that you offer here. So I would like to open it up for discussion and some questions. Yes.
I enjoyed that thoroughly. And this perhaps is beyond what you were studying, but do you have thoughts about how the Saskatchewan context would have been different than other Western Canadian provinces who were also dealing with these northern nursing issues? And did the CCF kind of ethos in the province shape that in a particular way?
I think it did, and the reason I'm saying that is because I was just looking at how the health regions were established in Saskatchewan. And one of the early movements when they were implementing the hospitalization care in 1944 was to establish regions. Now, what they did then, they established northern Saskatchewan as a region. So, but how it extended beyond that, I don't know if you can answer that, Lori. If it went into Alberta, I don't.
That's a tough one.
Yeah.
Not many regional studies have been done like you've done for Saskatchewan. We can't compare it to Quebec or to
Ontario.
Yeah. But I would say for Alberta, the structure of medical care from a nursing perspective is a little bit different than Saskatchewan. And yet the way the service is provided to those remote communities is very similar. Mm-hmm. So jurisdictionally, that's one aspect of it, but then the actual, that's why I like your theoretical model of Malone. It really does explain how close that service can get to a particular community.
Yeah, and I don't know if the government's actually established nursing stations in other parts of the north the way Saskatchewan did, but also I think it was in response to the very challenging conditions. Because the region had, in some ways it's a benefit, but the region had been utterly ignored, except for the Catholic Church and the Treaty Party that went in once a year, which has some benefits, but yeah, so.
That is, I don't know how that compares, but Jane Elliott has looked at the outpost nursing in Ontario.
Yeah,
that
right.
was Red Cross.
Yeah, exactly.
Yeah.
Red Cross.
So I don't know how that compares to.
They did, and actually, the Red Cross had. Thank you, Geertje. That's right. Red Cross ran a hospital. Buffalo Narrows was a Red Cross hospital. It was transferred to the provincial government when they implemented the system. Yeah, and they also had Red Cross had one in Prince Albert or Paddockwood was. So they did have that system. Yeah.
In Alberta, it happened the same way.
Yeah.
The Red Cross Outpost did go to
They had nursing orders. Catholic.
Just along that same topic, because I was interested in how it was done as well, and whether and a bit more about the role of the federal government health nurses that were assigned to specific areas, and I don't know what they did in Saskatchewan. Mm-hmm. The other thing is that in reading about northern British Columbia and early hospitals in early British Columbia, there were an awful lot of Methodist or Protestant-type hospitals started in northern BC. And in doing that reading, I'm discovering that they also went across northern Alberta and I think into Saskatchewan from, either started by the Methodists and then became United Church hospitals.
Right.
So I was wondering about that and sort of why you started with 27.
Why did I start with 27? I'm just going to bring this up here. Because that is when the provincial government started to take more of a role. When was Cumberland? Was 1929. That is why I started there. The person whose material I read first was the nurse at Cumberland House. So I looked at her materials. But up until then, aside from the Grey Nuns and through the church, there really was nothing. I haven't come across anything else other than I'm not sure how Evandy got there in 1929. I'm still trying to track that down because it wasn't government run. I don't know why she was there. Her and her sister bought a house there, and the sister leased the house out to provide as a hospital. But who paid for it? I don't know. Maybe it was another church.
And the Red Cross. So there's the Red Cross and the
they weren't there then. But it's interesting. It would be worthwhile looking a little bit closer at that. Yeah.
I'll look in and I'll send you if I find anything.
That'd be great. Thank you.
Hilda and then.
Yeah, just a question. How would the community have looked after the medical needs without these outposts? What did they do?
Well,
did they find a need for it, or did they actually have a system?
Well, they have their traditional medicines, but also, well, even if it didn't, I guess, yeah. Also, I think they knew of these other hospitals that were there, the Grey Nuns. Plus, some of them, I know in Pelican Narrows, the chief there wanted a nursing station in his community because he wasn't saying, I don't want traditional medicines anymore, but he could see some merit to that. So there was an attempt, in fact, they did get the federal government to establish that. But prior to that, it was depending on their traditional medicines. But I think also the RCMP provided care. The Indian agents, I wouldn't say care, sorry, medicines. The Indian agent, and when the treaty party came through once a year, that was on treaty days, right? They would do x-rays and give out medicines. And the Hudson Bay Company, too, had a supply of medicines. So.
Did anybody study their traditional?
Oh, yeah, I'm sure, yeah. In fact, I think many still use it because many of my students are from small northern reserves, and many still have a reliance on that. They use it in conjunction, right?
So they use it,
yeah. And again, that will vary. If people are more urbanized, there's not as much of a connection. But I would say the connection with people in the north back to their reserve communities is still incredibly strong. There's a lot of motion. It's hard to determine populations because of the back and forth movement. So, yeah.
When you speak of x-rays, and it draws me to think of tuberculosis as a condition that was pretty rampant in those times. And I do believe that the tuberculosis societies may have had some early part to play in those communities.
Yeah,
Did you find anything about
yes,
it?
and the TB Lung Association, they used to call it, right, in Saskatchewan, was Fort Capel. They had the hospital down there where there was. The concern was, and let me just say that I didn't put it up there, but the figures for TB in northern Saskatchewan, even to this day, are 17 times higher than in the south. But then it was many times higher. The concern was when the populations mixed. So that's when they got more proactive about providing x-rays. And again, this is why the nurses were saying, you can't provide, the federal party would come through, they would only x-ray First Nations people, not the Métis and non-Indian, because of the payment issue, right? And they're saying, how can we begin to address these issues if we don't x-ray everybody? And the nurses would go out and get everybody together for x-rays, and then the x-ray people would say, no, we can't x-ray them because they're not federal jurisdiction. But you're right, there's a long history there of Ferguson, who he did a lot of work with TB, and there's the hospitals. And again, I think it was because of the populations mixing, I think, was their main concern. Yeah.
What's your name, Bobby?
Priscilla.
Priscilla.
I was very interested in I'm interested in the whole thing, but particularly in your discussion of the interface that the nurses were experiencing between their interaction when people from the community came into their realm, and then vice versa, when they went into the community realm. And the reason I say that is because here in BC, our history in the last several decades, since the 70s, late 70s, early 80s, has been very interesting along that line, in that there's been the move from medical services, federal provision of care to reserves, to tribal managed care, and now the First Nations Health Authority in the last couple of years as a regional health authority for the entire province, based on First Nations teachings and based on commitments to First Nation. So to me, I found that very interesting because there must have been nurses. My question would be, there must have been nurses in that period of time that you were representing, the early period there, who were probably along the spectrum. Some who were more comfortable with what they were learning from the members of the community and how to interface with them, and others who were probably less comfortable with it, who were wanted to come with their colonizing work. So my thought would be, it would be really interesting for me, I would be very interested in finding out from the letters and from the documents, particularly from that group that understood it themselves as a place in that geography, in that landscape, with the people of that land, and how they developed and grew in their practice and what they had to say. I find
that's a good point, and there's many examples in the letter there, because some talk about it with passion, for the land, for the setting, for the people, and then there was, in some cases, tremendous recognition and respect for the traditional medicines, midwifery. They wouldn't intervene in some cases because they knew they had their limits. So you're right, it was along a spectrum, and it was very rich. That would be something really neat to pull out of that, because it was interesting too, because these nurses, these were all very well-educated, highly trained nurses. Many had gone with the Rockefeller Foundation to New York to get their public health training. But they were looking for something different, I think. And there weren't a lot of jobs for nurses at the time, so, they went there. But I think the ones whose letters I've got are the ones who lasted, right? And you could see them struggling with what they're being told through professionally, through their employer, versus what they were living with day to day. Just very, very different. But even some of them, it was one of them, some of these nurses had nursed in the war. And 2 German women nurses were stationed at one of the nursing stations. And they asked to be put together because during the war they had been in prisoner of war camps, isolated. And they said, please put us together because we need that. We've been isolated now. They refused to do it. So they left. But they were incredible advocates for the people in their community. Very strong advocates saying, we need this, this, and this. Why are you doing that? You need to pay more attention to the people in this region.
Yes. I had the privilege of meeting Jean Cunningham.
Oh, yeah?
And an immense privilege. And one of the takeaways from the time that I had the opportunity to spend with her was her capacity to listen and her humor. And the two, I think, she was very open to the non-Aboriginal person who had a genuine interest in learning.
Yeah.
So that bridge, that whole making of that bridge back and forth is just a huge piece, I think, of the gift that comes from the nursing profession.
Yeah.
I was just curious, I've worked in a high Arctic station in the Keewatin zone in the early 70s, and there were a lot of nurses from England who had midwifery training. Were these folks mostly Canadian-born and educated, or were they from elsewhere?
It was a mix. It really was a mix. Yeah, it was. Many were from Canada, from Ontario.
Yes.
But there were a lot of British nurses too, some German. But I would say it was a mix. I was surprised. I thought they would have all been British, but there was quite a few Canadians in there.
Starting to mix, obviously.
Yeah.
I was Canadian-born and out there, but there were still predominantly, and I think a lot of it had to do with the midwifery, which was interesting because that was also a real cultural difficulty because there were rules that the first baby and after, 5 or something like that, you were supposed to fly the women out. And of course, they didn't want to go out for obvious reasons. You're going to be separated from your family. So the same problem with treating TB, very problematic. Yeah. And so some of them would basically disappear on the land and go back to the traditional midwives. Yeah. Because they just...
I know one of the nurses that I've known her. I used to work with her many years ago, and she nursed in northern Saskatchewan at Uranium City. But she was saying one of the worst parts of her nursing was having to separate the families and send them south for treatment. She said it was awful. It was just terrible. But,
We had X-ray machines that we ran ourselves because it was medical services, so it's all federal. So there wasn't this issue of jurisdictional problem.
It's almost, like I say, it's almost easier, isn't it, in the Far North? It's clear cut.
Given these issues, I mean, to me, whoever came into the nursing station, I do remember, though, one situation where a white person went into the nursing station, complained about me to my bosses, basically because I insisted he wait in line. He needed a tetanus shot, and he told them I refused care, and what I did was say, this is not an emergency. Yeah. I'll get to you. Yes, you need to have this shot. So that was more basically saying, look, everybody is the same here. We treat everybody the same, and so it was different issues, but not the one around who's entitled for care. Just
well, sure. I mean, families are split jurisdictionally too, right? It's very messy, and
I can't imagine there were enough issues to
I think because NIFA is the Northern Intertribal Health Authority that provides third-level services in northern Saskatchewan to its reserves. It's 4 tribal councils that have formed together with the regional health district, and they're working at overcoming some of these jurisdictional differences. I think if the political will was there, because they do it in other places where you have provincial, like in Saskatchewan, everybody's covered provincially by everybody. You don't pay, and it comes through taxation. So there's not that. It's those extra services that apparently First Nations get, which tend to sort of shift with like moving goalposts where they try to.
Put your finger on it. It's about reducing the cost, right? That seems to be the driver.
Yeah, and the scary thing is, as the medical treatment then is very different to now, and the expectations are so different, and the costs are so extraordinary that, there's even, I think, a greater will to perhaps shift it. Yeah. Yep.
Well, I just add to your question, I know that the federal government recruited in England for these northern nursing positions. So that's where those British nurses came from. They were sought after.
What was it called? They had a society for recruiting nurses there, didn't they?
I don't remember. Yeah. Lesley and I did some research together many years ago, and so we've had some shared knowledge of it. And then thinking of that dilemma of interpreting what nurses did, where personally they may have been invested in understanding the community and had an appreciation for their place there, the land, the people, the culture, and all that. Still, they were always hamstrung, in my experience of looking at that material, by their role as a nurse. And they did represent that authority, and they did represent those rules, and there was only so far they could do to sidestep them without getting their own throat slit. So it's very difficult to try and offer some sort of judgment in relation to their openness to where they were working, because they were part of a system, and they wouldn't have been there if they hadn't been part of that system. So it's really, what I love, I guess I would just close by saying, I love how you presented that, and I really love your theoretical perspective to try and capture all those individual anecdotes, because we read them and they're all so compelling and interesting and intriguing, but then what do you make of it at the end of the day? So you've just inspired me on different fronts.
We're off on another journey, are we? Thank you. Thank you. Thank you. Thank you.